Good morning, everyone, and welcome to our Department of Medicine's Grand Rounds. I'm Dana Bowen. I'm one of the chief residents here. So I just wanted to do a few housekeeping tips. Before we get started, please just make sure your video is off and your mics are muted. We also ask that you hold your questions and comments till the end. You can place them in the chat box or unmute yourself at that time. Lastly, the CME information for today, I will put it in the chat box. It will also be during the presentation. So today, Dr. Swami Nathan, who's our head of the HIV and infectious disease department here, will be introducing our speaker. Thank you, Dr. Swami Nathan.
Hi, thank you, Dana. And just to clarify, I'm not the head of the infectious diseases. Our chief is still David Eland. I guess I would say I oversee the HIV treatment and prevention pieces of the program. But anyways, thank you for that. And as many of you know, tomorrow, December 1st, marks our World AIDS Day. And we've come a long way. I was just reflecting, I kept thinking, okay, it's been more than 30 years. And I realized, no, it's actually 40 years because HIV, the infection was first discovered in 1981, and 3 years later, the virus, we identified the pathogen. And we've certainly come a long way from no therapy to monotherapy to medications, 5 times a day to a simplified regimen, something as simple as even 1 pill once a day with just 2 pills in it. But I think right now we stand at a cusp of a shift in the treatment paradigm with respect to how we approach HIV treatment with respect to long acting. And when I was trying to figure out who to invite, and I thought I could think of no better person than my friend and colleague, Dr. Trip Gulick. And I don't know if Trip remembers, but the first time, my very first presentation at a conference, Dr. Gulick was the moderator and was very supportive at that time, long time ago. Dr. Gulick is the Rochelle Belfer Professor of Medicine and Chief of the Division of Infectious Diseases at Weill Cornell Medicine. He's board certified in both internal medicine and infectious diseases, and his research interests include designing, conducting, and analyzing clinical trials, particularly as it relates to novel antiretroviral therapies and strategies for both treatment and prevention of HIV infection. And I'm so happy to say that he's the principal investigator of our joint clinical trials unit at Weill Cornell, New Jersey Medical School. That's NIH funded to do both HIV treatment and prevention research through the ACTG and HPTN networks. And today marks the completion of year 8 of our successful unit, and tomorrow marks year 9. So thank you, Trip, for your leadership of our unit. He also serves as co-chair of the US DHHS panel on clinical practices for treatment of HIV infection. He's a board member of International Antiviral Society, IAS, and has previously served as member and chair of the Antiviral Drugs Advisory Committee of the US FDA. He also most recently serves as co-chair of the NIH COVID-19 treatment guidelines panel, is a member of the American Society of Clinical Investigation, Association of American Physicians, IAS, and IDSA, and has presented at multiple national and international meetings and has published widely. So without further ado, it is my pleasure to invite Dr. Gulick to give our World AIDS Day speak talk. Thank you.
Shobha, thank you so much. Can you hear me and see my slides?
Yes, loud and clear, all good.
Okay, great. 2021 marks the 40th year since the first cases of AIDS were described. And back in those days, everyone died within 1 to 2 years. We have made remarkable progress, and that's the focus of my talk today. Antiretroviral therapy, past, present, and future. I have no disclosures. As mentioned, I'm the co-chair of the US Department of Health and Human Services Adult and Adolescents ART Treatment Guidelines panel, and I will be featuring the guidelines recommendations at times during the talk. This is for your information, the text code 11732 and the phone number. So this was the report. in the Center for Disease Control Morbidity and Mortality Weekly Report, MMWR, June 1981. Now, this wasn't the headline. This wasn't even report number 2. This was buried deep within the MMWR. It was article number 3. And it said pneumocystis pneumonia, Los Angeles, in the period October 80 to May 81, 5 young men, all active homosexuals, were treated for biopsy-confirmed pneumocystis pneumonia. We now know that those were the first 5 cases of AIDS described on the planet 40 years ago. As of the latest statistics from last year, over 79 million people have been infected with HIV since the beginning, and over half have died. But the other half are currently living with HIV because of significant progress in treatment. That's illustrated for you here. These are UN estimates. These are global. What you see here in red are new HIV infections. And you see that they peaked at over 3 million new infections per year in the mid-1990s, but have had a steady decrease since that time. In blue are HIV-related deaths, and you can see the peak there is about 2005, 2 million deaths per year. And again, that's declined as well. So why are new infections and HIV-related deaths declining in recent years? And you know the answer. It's a number of factors, but probably most importantly, effective treatment and effective prevention. Well, this is the grandparent of antiretroviral therapy. This is a thymidine analog, so looks very much like the DNA-based thymidine with one substitution here, and that's an azido substitution. Should be a hydroxyl group if this was thymidine. So this is azidothymidiene, or AZT, also known as zidovudine. This was sitting on the shelves of the National Cancer Institute as a failed anti-metabolite, anti-cancer drug. When HIV came along, many different compounds were tried, and this was one of the first to show efficacy against the virus. It works as an HIV reverse transcriptase inhibitor. So reverse transcriptase does the opposite of nature, transcribing a viral RNA template, as shown for you here, into a viral DNA copy of that. So here's viral RNA. There's an adenosine matching with the thymidine, cytosine matching with the guanosine. Here's the next base in line. It's an adenosine, and it could match here with this thymidine or this thymidine, or it could match with this one that looks a lot like thymidine, except it has the azido substitution. So if that one gets incorporated in the chain, here's the action shot here, boom. Then N3, the azido group, results in DNA chain termination, and the process is not permitted to go forward. HIV replication is interfered with or stalled or even stopped, and that's the mechanism for the HIV reverse transcriptase inhibitors. This was quickly moved into a clinical trial that was reported in 1987, so conducted in the mid-80s. It was a double-blind, placebo-controlled study. It enrolled people with AIDS, or what we called at that time ARC, which was AIDS-related complex, meaning symptomatic HIV disease. And you could see 282 people were enrolled and randomized to receive AZT by itself or a matching placebo. They were followed for 24 weeks, and the study endpoint here was death. There was one death, sorry, that should be reversed, in the AZT group and 19 deaths in the placebo group, and that was highly statistically significantly different. The graph shows AIDS-related opportunistic infections, and you can see fewer of them in the AZT group compared with the placebo group. Their conclusion overall in this study was that AZT decreased both mortality and opportunistic infections over 24 weeks. There was a lot of excitement generated by this study, but unfortunately, these beneficial clinical effects would be short-lived, and most of them would be no different in the next 24 weeks. Well, we went on with new drug discovery, and the nucleoside analog reverse transcriptase inhibitors became a focus of drug development. You could see the 4 DNA bases here: adenine, cytosine, guanine, and thymidine. And I just mentioned zidovudine is a thymidine analog. 2 other nucleoside analogs became ready for clinical trials: didanosine, which is an adenosine analog, and zalcitabine, or DDC, which was a cytosine analog. Taking a chapter from infectious diseases, we began to look at combination therapy in the mid-1990s. Shown for you here in a table are 3 large studies: AIDS Clinical Trial Group 175, Delta 1 and 2, that was conducted by the Europeans, and another NIH-sponsored network, CPCRA 007. Note that they enrolled literally thousands of people, different CD4 cell counts, but the basic design was the same. It was, are 2 nucleoside analogs better than 1? For ACTG 175, the 4 study arms were AZT by itself, DDI or didanosine by itself, AZT DDI combination therapy, or AZT DDC combination therapy, and the other 2 large studies, similar arms. Overall, they found that combinations of 2 nucleosides were better in terms of clinical endpoints than a single nucleoside. And that was true in both the large ACTG and European studies. Interestingly, not true in the CPCRA study, which enrolled people with lower CD4 counts. When these results became public, 2-drug therapy became the standard of care almost immediately. Well, drug discovery continued, and in addition to reverse transcriptase inhibitors, another HIV-specific enzyme was targeted. When virions bud off from an infected cell, they are in an immature form with long precursor proteins. These require a specific enzymatic cutting activity by an enzyme called HIV protease. Only when that step occurs does full maturation and infectiousness of the viral particle continue, and it's able to reinfect another CD4 cell that it comes into contact with. So the protease was a target for drug development, and as you can imagine, this led to a new class of agents called the HIV protease inhibitors in the mid-1990s. Well, when we had a new drug, we also began to think about new strategies, and that is combination therapy with 3 drugs versus what was the standard of care, 2 drugs. I was fortunate to be a young assistant professor and be involved with one of the first triple drug therapy studies called 035. And this enrolled a small number of people, fewer than 100, randomized them to 3 regimens: AZT 3TC, that's a dual nucleoside reverse transcriptase regimen, that was the standard of care; Indinavir, which was one of the new protease inhibitors, and we gave it as monotherapy because of the potency of this drug. And then a novel approach was a 3-drug therapy: AZT, 3TC, and Indinavir. We followed people originally for 24 weeks, and we had a new metric to guide response. So rather than collecting clinical endpoints, we used a new test that was the HIV RNA test, also called the viral load level. In this case, the lower limit of detection was less than 500. That was a new concept. Could you really reduce HIV RNA levels below a limit of detection? Well, of course, today we would take that for granted, but back then we didn't even know what to call it. So we would say suppressed below the limit of quantitation. Today we'd call it undetectable. And here are the results at 24 weeks. Dual nucleosides, no patient was below 500 copies. Indinavir monotherapy, 43% of the patients. But what truly was astounding at the time was the triple drug group. 90% of the enrolled patients suppressed their viral loads to less than 500 copies per mil. That had never been seen before. A parallel study ACTG 320 enrolled over 1,100 patients. This was led by colleague Scott Hammer, and I'm sorry to tell you that Scott actually died just within the last 2 weeks, quite suddenly, and we remember him well. One of his greatest contributions was this study, which looked at a comparison of AZT3TC, again, the standard of care at the time, versus that same triple drug therapy, AZT3TC and Indinavir. Over a median of 38 weeks, triple drugs reduced clinical endpoints, that is AIDS or death, over two drugs by 50%, a remarkable accomplishment. Well, why did it work? When we used one drug in 1987, AZT, what's graphed for you here are viral load responses, and it's on a log scale. So one drug led to a 90% reduction in viral load levels, but what you saw next was a rebound. And if you characterize these viruses here, you would find AZT resistance. When we had two drugs, we used them in the mid-90s, two nucleosides, that resulted in a more profound drop in viral load level, 99%, but rebound occurred here, and some of the viruses were now resistant to both drugs. When we used three drugs, two nucleosides and a protease inhibitor, you saw a profound drop in viral load, but even more importantly, you did not see a rebound. HIV replication was being suppressed to the degree that resistant virus could not emerge. And this graph shows 24 weeks. We now know that we can keep people suppressed on appropriate therapy for decades. People used more than three drugs. Other studies looked at 4, 5, and 6 drugs. None of them did any better than 3. This quickly became the standard of care for people with HIV infection. And it showed remarkable changes. What's shown for you here are CDC death rates and the most common causes of death for men and women in the United States aged 25 to 44. So young adults, we're looking at 1987 through 2001. And you can see with the colors, the most common causes of death in this group are accidents, cancer, heart disease, suicide, and homicide. Out of nowhere comes the red line, which is HIV disease. It becomes the #1 killer of young men and women by 1994 and 1995. Remember, that's the years where triple combination therapy was first studied. And what happens next? Triple combination therapy was adopted, and the death rate from HIV dropped by 2/3 in 2 years. That's really a remarkable accomplishment in all of internal medicine to see such a dramatic change in the death rate. Well, what were the problems with these early regimens? Yes, side effects was a big problem, and there were a number of them with the triple drug regimens that were used at the time. In addition, these were complicated regimens. Here's what it's like to take triple combination therapy in 1996. And here's the one we've been focusing on, AZT, 3TC, and Indinavir. At 8 a.m., you needed to swallow 7 pills. And then exactly 8 hours later, another 6 pills. And then exactly 8 hours later at 12 midnight, 7 pills. That's 20 pills divided every 8 hours for the rest of your life. It's life-saving. In addition, you had to be fasting. So taking these either an hour before or 2 hours after eating. And finally, you needed to drink a liter of hydration a day because Indinavir causes kidney stones, and that would be a preventative. So although these were life-saving medications, very few people could actually keep up with the demands of this regimen. So if the first 10 years of antiretroviral therapy was to identify potent regimens that were effective, which we did, the next 10 years was focusing on reducing side effects and making these regimens more livable. So go forward 10 years to 2006, here's what it's like to take triple combination therapy. 1 pill once a day at bedtime, and it's not really this big. That quickly became the standard of care, one pill once a day, popular with providers, very popular with patients. Another class of agents was also developed called the HIV integrase inhibitors. We're in the middle of the viral life cycle here. So viral DNA has just been reverse transcribed from viral RNA, and its process forms a double-stranded complex that enters the nucleus and then is randomly inserted in the host cell genes. At that point, the cell is infected for life with the viral genes incorporated. The enzyme that assists both in the transport of DNA and its incorporation is called HIV integrase, and this too became a drug target. HIV integrase inhibitors emerged as being potent, well-tolerated, and convenient, allowing once-a-day dosing. And these quickly became adopted. So where are we then today in 2021 with antiretrovirals? Well, studies have shown us that starting antiretroviral therapy at all stages of HIV infection has clinical benefits, and that's now the standard of care for the entire world. There are 33 FDA-approved drugs in 5 broad mechanistic classes. I mentioned the nucleoside reverse transcriptase inhibitors, or NRTIs. There's another class called non-nucleoside reverse transcriptase inhibitors, or NNRTIs. Protease inhibitors are the PIs, integrase inhibitors, and then several types of entry inhibitors. Initial antiviral therapy regimens worldwide based on clinical trials have one standard strategy, and that is 1 to 2 nucleoside reverse transcriptase inhibitors in combination with an integrase inhibitor. For virologic failure, the next regimen should include at least 2 active drugs, one with a high barrier to resistance. And finally, the way we've made progress is to focus on antiretroviral properties, the antiviral activity, the safety and tolerability, and the convenience. So let me take the opportunity to review these 3 properties. And noting that we have developed 33 FDA-approved drugs since the very first one, AZT, in 1987. The drugs are shown for you here with their 3-letter codes. You can see substantial progress since 1987 all the way to earlier this year. The 33rd drug, an integrase inhibitor called Cabotegravir, was approved. So here are the 33 drugs, this time organized by mechanistic class. So the left column are the reverse transcriptase inhibitors, the nucleoside analogs, NRTIs, and the non-nucleoside analogs, the NNRTIs. The protease inhibitors are listed in the middle, entry inhibitors of 4 different kinds, and then integrase inhibitors, and we now have 5. And note the subnote here, 5 of the 33 drugs have been discontinued from the market, either because of toxicity, inconvenience, or because better drugs came along. So what about antiretroviral activity? Well, my colleague, Dr. Carr, down in Australia, took a look at antiviral studies and their virologic responses and published this in the journal AIDS a couple years ago. And he looked at 354 antiviral studies through 2017 that were conducted with intent to treat analyses involving just under 78,000 people. And what we're looking at here is efficacy in terms of viral load suppression. And you can see that the trend goes up, so better efficacy over time. Back in the mid-1990s, 45% efficacy, up to 2017, 77% of patients suppressing their viral load levels on various regimens. Well, did we stop there? No, we kept going. So here are a number of recent studies published in the last couple of years. You can see testing hundreds of people on different regimens. And if you scan down the list, most of these are 3-drug regimens, and the response rates at 48 weeks using a lower limit of detection of 50, you can see that we go to 89, 90, 91, even as high as 92, 93, 94% of people suppressed their viral load levels on these current regimens. Many of these are integrase inhibitor-based regimens. Well, what about safety and tolerability? Andrew Carr looked at the same thing with those 354 studies, intent to treat analyses with the same 78 almost patients, but this time looked at people who discontinued the regimen because of treatment toxicity. And again, what you see is that decreased over time. So back in the 90s, as many as 10% would stop their antiretroviral therapy because of toxicity, but by 2017, that was down to 4%. Did we stop there? Well, again, no. So here's a number of more recently published studies looking at more contemporary regimens, studying hundreds of people. Again, all of the regimens you see here are integrase inhibitor based. What percentage discontinued for adverse events over 2 years or 96 weeks? And you can see 3, 2, 1, even 0%. So regimens have gotten more potent and less toxic over time. And then what about convenience? Well, I already celebrated one pill once a day. Turns out that's a very popular approach. Here are a number of FDA-approved single tablet antiretroviral regimens. You can see again the first one back in 2006, but then we've had a progression of them. And a number of these are available both in the United States and around the world, including in developing countries. One pill once a day therapy works. And this has led to the current US Department of Health and Human Services treatment guidelines, recently updated at the end of August. These are recommended initial antiviral regimens for most people. And the basic structure is 1 to 2 nucleosides with an integrase inhibitor. And you can see we've narrowed now to 2 integrase inhibitors, either Bictegravir with 2 nukes or dolutegravir with 2 nucleosides, or even a 2-drug regimen, dolutegravir and 3TC. Now, I've been talking about triple drug regimens all this time. Where did 2 drugs come from? Well, from randomized clinical trials. Dolutegravir is a potent, well-tolerated drug, as is the nucleoside reverse transcriptase inhibitor 3TC or lamivudine. This 2-drug combination was non-inferior to 3 drugs in 2 large studies, and that led to their FDA approval. Well, these regimens now have become common worldwide. Here are the World Health Organization, or WHO, recommendations for first-line antiviral regimens for adults living in lower and middle income countries. And the preferred regimen is the same as here in the US, 1 pill with dolutegravir and 2 nucleosides. And the alternative is the non-nucleoside efavirenz with 2 nucleosides. Again, 1 pill, once a day therapy. So that has now become the standard of care for the world. Well, how well do people do on these regimens in clinics? I've been showing you clinical trials data. We're all aware that as you roll things out into clinical settings, people may not do as well. Turns out with antiretrovirals, they do as well. These are New York City data on 62,000 New Yorkers living with HIV and taking antiretrovirals. And you can see 89% are suppressed below the limit of detection. That's remarkable. They also published individual hospital results. And here's our data from Weill Cornell. We follow just over 2,300 patients living with HIV, and our suppression rate in our clinic is 93%. I suspect yours is the same. And actually, we see these kind of numbers now, not just in developed countries, but in developing countries, better than 80% suppression rates around the world. And these have led to increased life expectancy. As people control their viral infection, they do not clinically progress. And so we reduce AIDS and death. And that's shown for you here from data from Denmark. So Denmark follows everyone with HIV over time. What's graphed for you here are life expectancy in all Danes living with HIV, and this is survival from the age of 25. So first of all, look at the population controls. So Danes living without HIV, the average survival is about 80 years old. So that's the average life expectancy in Denmark. Well, back in 95, 96, that's before triple combination therapy, you can see that the average Dane with HIV only lived to age 35. With the widespread use of triple combination therapy over the next 2 years, you can see life expectancy increase from 35 to about just under 55 years of age. Remarkable change. And that didn't stop as regimens got increasingly potent, less toxic, and more tolerable. You can see that the life expectancy approaches that of the general population. Well, that's Denmark. How does it go here in the US? Recently published data from Kaiser Permanente, the large insurance coverage system, looked at life expectancy. And they studied a cohort of adults living with HIV who were in care in the Kaiser group over 17 years. And this was a large group of 39,000 people. They matched them 1 to 10 with uninfected people, so just under 390,000. The study population was diverse. Average age was 41. You can see good representation from Asians, Blacks, Latinx, men who have sex with men, heterosexuals, injection drug users, all represented in this cohort. And what we're seeing here is life expectancy years. In blue is the HIV negative population, and in orange is the HIV, people living with HIV. So you can see this narrowing from the year 2000 up until the year 2016. And in fact, if you looked at people who started antivirals before their CD4s decreased to less than 500, that's normal level of CD4, there's absolutely no difference in life expectancy than the general population. So what a powerful message this is for us to talk to someone who's living with HIV and say, if you take your antiretrovirals, your life expectancy is the same as the general population. Remarkable. Here's the HIV deaths in the United States from 2010 to 2018. Total deaths are shown in the solid blue line, and you can see the rate decreasing in recent years. That's all accounted for by the dotted line, which are HIV-related deaths, which have continued to fall. Interestingly, non-HIV-related deaths have remained rather stable. HIV-related deaths down 50%. And this is true worldwide. So what we're looking at here is UN data. AIDS-related deaths, nearly 2 million people dying per year in 2003, and that is down more than 50% at this point to 2018. And coincident with what's shown in the red line, antiretroviral therapy and how many people are taking it. So going from almost 0 in 2003, you can see currently, these are 2019 data, nearly 25 million people taking antiretrovirals. Latest estimates are about 2/3 of the world's population living with HIV are taking antiretrovirals today. So a remarkable success story. Here's what's called the global cascade. So all people, 37 million people living with HIV on the planet, how many people know they're HIV infected? And the answer is 84% of them. If you look at how many of them are on antiretroviral therapy, it's 87% of those who know they're HIV positive are taking antiretroviral therapy. That's 73% of people on the planet living with HIV. And then of those taking ART, 90% worldwide are virologically suppressed and controlling their virologic infection. If you do the math, that's 66% of people living with HIV. So remarkable accomplishment globally. Well, antiretrovirals not only prevent clinical progression, but they also prevent transmission of HIV. This was a large study that was conducted with the HPTN, the HIV Prevention Trials Network. They enrolled over 1,700 discordant couples, meaning one living with HIV and the couple in a committed relationship without HIV. 97% of these couples were heterosexual, diverse areas of the world, and the HIV positive partner had a CD4 count between 350 and 550. So most areas of the world would not have started that person at the time this study was being done on antiretrovirals. The study design was that the positive partner randomized to start ART immediately or deferred until the CD4 count dropped below 250, which was the standard of care at the time. The outcome of this study was infection in their negative partner. And there were 46 cases of linked cases to the positive partner. Only 3 occurred in the group on antiretroviral therapy. 43 occurred in the partners who had not yet taken it. So that's a 93% reduction in HIV transmission. That is, antiretrovirals are not only treatment, but they are prevention. And we've now taken that one step further to the concept of pre-exposure prophylaxis. That's a strategy of administering antivirals to uninfected but at-risk individuals. Because this is a preventative, you'd want it to be potent, safe, tolerable, and convenient. And the initial drug tested was co-formulated TDF and FTC, a single pill. There were some concerns about that. We used this for treatment. Would we engender drug resistance? What about toxicity? What about cost? But phase 3 studies demonstrated efficacy and safety, and that led to FDA approval, first country in the world in 2012, one pill once a day, TDF FTC, as a preventative, as PrEP. And then a newer formulation of tenofovir with less toxicity was approved in 2019. Again, one pill once a day for PrEP. Well, here's recent PrEP studies from the UK and from France and Canada. They enrolled hundreds of HIV negative men who have sex with men, so at risk for HIV, and gave them either daily PrEP immediately or delaying it, or an on-demand strategy for PrEP versus a placebo. All in all, PrEP was associated with an 86% reduction in new HIV infections. That's quite remarkable. In fact, in people who are fully adherent to PrEP, it's likely to be 100% protective. Well, one pill once a day doesn't work for everybody, particularly younger people who may be at risk for HIV. So we, and when I say we, I mean Cornell and New Jersey Medical School, were part of the very large HPTN 083 study. So this looked at PrEP with an injectable antiviral called Cabotegravir, which is an integrase inhibitor, versus the standard one pill once a day. This was a randomized, double-blinded international study of PrEP in high-risk adult men who have sex with men and transgender women. And it enrolled over 4,500 people. And again, both my place and your place were part of this study. 2/3 of the enrollees were less than 30 years old, so they were young, 12% transgender women, and in the US sites, 50% were African American or Black. They received CAB injections every other month versus TDF FTC standard of care, one pill once a day. The Data Safety Monitoring Board stopped this study early because of a significant difference between the two groups. And here's what they found. So new HIV infections, and that's what's shown for you here is the incidence. There were 13 in the Cabotegravir group versus 39 in the TDF FTC group. So that is, as it turns out, significantly better. Cabotegravir was not only non-inferior to one pill once a day, TDF FTC, but it was superior. Now, these data are under evaluation currently at the FDA, And we expect to hear about approval of an injectable form of PrEP that will help many of our patients. Well, in fact, all of the progress that we've made has led the federal government to plan to end AIDS by 2030. And here is the plan. How would they do it? Diagnose people living with HIV as early as possible, treat the infection with antiretrovirals to achieve a sustained viral suppression, use prevention, including PrEP, to protect people at risk, respond rapidly to clusters or outbreaks of HIV, and make sure the HIV health force is strong. And lots of support for doing this moving forward. All right, that's past, that's present. What about the future? What can we expect next from antiretroviral therapy? Well, the first thing to look at is antiretroviral activity. Our present regimens are highly potent in people who have never taken antivirals or who have failed 1 or 2 regimens. But the place we have room to grow here are people with multi-drug resistant HIV. Multi-drug resistant HIV in treatment experienced patients today is relatively uncommon, but of course we need options. And the good news is that we have a strategy. So what we do is look for a new drug or 2 with full activity, and then optimize the background antiviral regimen based on history and drug resistance testing. There have been 3 drugs recently approved. Ibalizumab is an HIV entry inhibitor. Fostemsavir is a different kind of HIV entry inhibitor. And an investigational agent in a brand new class of drugs called capsid inhibitors is lenacapavir. 3 studies of highly treatment experienced people with multi-drug resistant HIV show, with this strategy of adding a new drug and optimizing the background regimen, you can resuppress 43, 60, even up to 81% of people with multi-drug resistant HIV. So new drugs with new mechanisms of action are going to help this particular patient group. What about safety and tolerability? Again, the drugs we have today are quite well tolerated. Could we do better? Well, there's some strategies that people are exploring. I already mentioned that some 2-drug regimens have been non-inferior to 3-drug regimens. And the one that really stands out is dolutegravir 3TC. So the large Gemini study looked at initial therapy, found that 2 drugs was non-inferior to 3. The Tango study took people who were already suppressed on 3 drugs and randomized them to continue what they were doing, it was working, or switch them to this 2-drug regimen. And the 2-drug regimen, again, non-inferior. So 2 drugs may be a way to decrease toxicity. Some studies have studied lower doses of some of the antivirals and found some early success. And then as featured, newer drugs that have been developed over time are less toxic than older ones. And probably the best example is the protease inhibitor darunavir, one of the more recently approved ones, less toxic than older protease inhibitors. And as I featured, integrase inhibitors really have jumped to the front of the line because of tolerability and improvement over non-nucleosides or protease inhibitors. Lastly, convenience. This may be the biggest step forward we see in terms of antiretrovirals. Well, what's more convenient than 1 pill once a day? That works for an awful lot of people, but not everybody. So we're looking for options. The first is an injectable antiviral. So I've mentioned Cabotegravir several times. That's an integrase inhibitor similar to dolutegravir. Works as an oral formulation, but the excitement about this drug is that there is a nanotechnology formulation making it injectable. And you can dose it monthly for treatment or every other month for prevention. And phase 3 studies have shown that an all-injectable regimen, cabotegravir and the non-nucleoside rilpivirine, for people who are suppressed, maintains viral loads undetectable over time. So you can imagine that some people would be interested in an all-injectable regimen so that they didn't have to take pills. The US FDA approved this combination of all injectable CAB and rilpivirine earlier this year for switch treatment for people who are undetectable on antivirals without drug resistance and without chronic hepatitis B, because neither one of these drugs has activity against hepatitis B. The US FDA is currently evaluating giving it every other month. It's now approved for every month. And as I mentioned, looking at CAB alone as an HIV PrEP agent. So the first injectable antiretroviral regimen for treatment and for prevention. Well, there's more. So there's some investigational agents in the pipeline which are quite intriguing. Some of them are in existing classes. So islatravir is an investigational nucleoside analog, reverse transcriptase inhibitor, currently in phase 2/3, has an exceedingly long half-life. It can be given orally once a day. It can be given oral weekly, a weekly dose. So imagine an antiviral regimen that people just had to take once a week. For prevention, it could be given monthly. So take one pill once a month. And then they're developing implants similar to contraceptive implants that could be put in every 6 to 12 months. So imagine an antiviral implant regimen. There's MK-8507, that's an investigational non-nucleoside currently in phase 2. It too can be given orally on a weekly basis. So you're already seeing drugs that could be combined in a multi-drug regimen. There are also newer classes coming. I mentioned the capsid inhibitor lenacapavir, which had activity in treatment-experienced patients. It currently is in phase 2/3. It too can be given oral weekly dosing, and it can also be given as a subcutaneous injection, has a very long half-life, only every 6-month injections. And then there are monoclonal antibodies that can be given every 3 to 6 months as subcutaneous injections or intravenous infusions. So regimens of the future, what might they look like? Well, once weekly oral dosing. Combinations of these agents I just featured perhaps could be co-formulated, and then every Sunday, for example, one takes their antivirals once a week. Injectables I've already talked about, currently every month, but maybe less frequently, every 2 to 6 months with some of the newer drugs. I mentioned the implants. Here is an example of it. The drug is inside the implant and elutes over time, and the implant inserted just below the bicep muscle. And some of these implants are actually biodegradable, so they just dissolve over time. And then finally, what about a patch? Yes, they're working on antiretroviral patches, and some of the drugs have already been formulated into this. So all of this may be antiretrovirals of the future. Pretty exciting, and pretty exciting not just for HIV, but all of internal medicine. We're really paying attention to convenience and making use of new technologies that should promote adherence. Well, in conclusion, ART, past, present, and future. In terms of the past, I showed you we went from 1 to 2 to 3 drug combination regimens, and tolerability and convenience have improved over time, as has potency. Today, present, we have 33 drugs. Integrase inhibitor-based therapy is used worldwide. These are potent, well-tolerated, and one pill once a day oral regimens. And for the future, we want increased potency and tolerability, and probably the biggest advance we will see is convenience. So oral weekly dosing or new injectables, implants, and patches. Lastly, I want to acknowledge our supporters. I particularly want to recognize the partnership between Weill Cornell and Rutgers, New Jersey Medical School. My colleague and friend Shobha Swaminathan leads a great team of investigators and staff, and it's been such a pleasure to work closely together, both on treatment studies and prevention studies. We are a great partnership. As Shobha said, tomorrow we start our 9th year. That's a pretty successful marriage, I think. I also want to recognize your head of infectious disease, Dave Aland. Dave and I have been friends, Dave, wait for it, for almost 40 years together. We were med students and residents at the same place, Columbia here in New York. And I'll recognize the feds who have been supporting our clinical trials for treatment for many years, and more recently for prevention, and most recently for COVID. I left some time and I would welcome your questions. So thank you.
Dr. Gulick, thank you for this wonderful presentation this morning and review of where we are and where we are yet to go in treatment of HIV. And as somebody who was training while we saw the ravages of this, it's really just tremendously heartwarming to see and what's been done over time. And thanks to you for all of your contributions, and also, as you noted, our program here, Dr. Swaminathan, who's also done just great work, and the partnership and what you guys have achieved, not just for in the US, but worldwide. It's just something that's just remarkable and to be, highly emulated. So just want to encourage people to any questions. I'll just start off perhaps, and then also Shoba would love to get some comments from you as well. The issue around resistance, just to kind of ask a little bit more about that. Is that a function of duration of therapy, genetic predisposition, the strain of the HIV? And is there some insight early on in somebody's illness to predict about that and the emergence of resistance? Just your thoughts about that.
Sure. The reason resistance is such a problem with HIV is because are two factors. One is the sheer numbers of viruses. So in terms of replication, it's literally thousands and thousands of viruses that are produced in an infected individual who's not on therapy. And the second thing is that HIV frequently makes errors, so frequently makes mutations and has no processes to correct those. There are no corrections. So consequently, when someone's infected with HIV, we call it that they are infected with a swarm of viruses. It rapidly changes and nearly every mutation occurs relatively quickly. So then when you bring in drug pressure, you select out the resistant variants. A similar story to, I think, what we're seeing with COVID. So the important principle is to get regimens that can completely or almost completely suppress replication. Then you suppress the emergence of resistance and the therapies continue to work.
Thanks very much. I mean, thank you. So some patients don't develop resistance. Is that
correct? So as long as people take their medications and suppress their virus, resistance does not occur, or I should say occurs very rarely.
Thank you for that. Other comments or questions? We have the question from one of our hospitalists. Please comment on the perspective of curative therapy for HIV.
Great. So I didn't say the word cure today. We were talking about antiretrovirals. The short story is antivirals can control HIV, but they cannot cure the infection. And that's because of the viral genes being incorporated in the CD4 cell genes, and there are long-lived CD4 cells. They can live essentially the lifespan of a human being. Nevertheless, there have been reported cures in extreme circumstances involving bone marrow transplant, radiation, chemotherapy, anti-rejection meds. There have been a handful of people who are considered to be cured. And this is a huge research agenda right now, looking at novel ways, everything from trying to clip out the genes with CRISPR technology to activating the cells and then killing them. So this is an active form, or lots of research going on, and I'm pleased to say we're a part of it here. We have 3 laboratory investigators who are working very hard on cure strategies right now.
Thank you. From one of our infectious disease physicians, Dr. Della Piazza, regarding the issue about global equity with respect to the single tablet regimen. If you could speak to the safeguards for equitable access to more convenient formulations as they become available.
So thanks for that question, Michelle, and thanks for being part of our unit too. I think things are evolving over time. Just to take us back, before 2000, there were very few antivirals available for developing world countries. And people said, that's not fair. Let's get these technologies and let's get the pills out there. And I have to say, the US took a leadership role in this. The PEPFAR program, which is the President's Emergency Plan for AIDS Relief, funded antiretrovirals for the developing world. And the developments that we got also quickly translated through generic companies to developments in all parts of the world. And we had the finance really led by the US, the finances to support that program. As mentioned, there are 27 million people on antiretrovirals worldwide. Now, Michelle's saying, what about all these new developments? Will we get implants and injectables for the developing world? And I can tell you that those conversations are going on right now. So there is will to try to do that.
Dr. Swaminathan, you have some comments or
yeah, sure.
Thank you again, Shobha, for the incredible work, and people I think here certainly know, and I think around the country also know it, all the great work that you have been doing here.
So first of all, thank you so much, Trip, for an amazing talk. It's really, sometimes we take things for granted, and I think giving people, particularly the house staff who may not have seen what ART was like a few years ago, perspective is really important to just show how much we've done. And, and I think the long-acting injectables are really show optimism for the future, particularly as it relates to the 10 to 20% who are still not controlled potentially for directly observed therapy. And while you're correct that ARTs really aren't going to cure HIV for the reasons you mentioned, do you want to touch briefly upon work that the ACTG is doing as it relates to functional cure, and how these new agents might come to help with that?
So Shobha's focusing on an interesting point. When we say HIV cure, there are two types of cures. Usually we think in infectious disease of a sterilizing cure. So meaning that there's no trace of the virus in the person after infection. That works for other diseases, bacterial illnesses, some other viruses, et cetera. For HIV, as mentioned, that's been a very rare occurrence. Perhaps only 3 times in the world has someone had a sterilizing cure. A functional cure is a different idea. That is that you don't completely remove the virus, but that viral replication is controlled even in the absence of any specific therapy. And so that's a novel area of research that's being explored as well. Some of these long-acting agents perhaps could lead to a functional cure, and that's being tested right now. We don't have anything today for sure, but there have been reported cases of functional cure as well, including one recent report in the annals that just came out, a woman from Argentina who looks like she is fully cured. Earlier therapy probably increases the chances of that, but we'll have to wait and see.
Thank you.
Thank you, Dr. Gulick, again for just a wonderful, wonderful talk, and really tracing the evolution of treatment for HIV in very clear terms, and understanding all the mechanisms and the strategies and the thinking about this. Really fascinating. I want to thank everybody for joining this morning for this Grand Rounds. I hope you found it as interesting as I think, as certainly as I did, and learned a great deal. So again, Dr. Gulick, thanks so much, and thank you all for joining this morning.
Thanks.
Have a great rest of the day. Thank you so much.